So it's about our patients having a good quality of life. They still enjoy eating. It's not about them giving up everything they like, right?
Well, with both operations, the band and the bypass, you find that the patients tend to make better food choices because they realize they're limited on how much they can eat. So they don't want to fill up with some of the heavier carbohydrates like your breads and tortillas and pastas, because they know that might be all they get, whereas if they have some of your protein, fruits and vegetables, it's probably going to be a much more well-rounded diet, but they're going to make those choices because they know they can only eat so much.
Kind of automatically. Behavior modification, but automatic.
Well, part of it's automatic, especially on the restrictive component, so a small pouch with the bypass and a small pouch with the band. When you add the part malabsorptive component or little bypass part of the Roux-en-Y gastric bypass, part of that also is an aversion, and that's what has been described as sugar dumping. And that's not the dumping like a ulcer dumping where you're running to the bathroom to go to the bathroom. The sugar dumping is an actual insulin reaction, and it's more related to the way the food is presented to the gut. So by that, having that little bypass where the stomach gets to the intestine a little quicker, the pouch gets to the intestine a little quicker, if you eat something real high in sugar or real high in fat, the patient's going to feel kind of their heart race, they're going to feel kind of clammy and sweaty, and it zaps their energy for a couple hours. Most people are convinced next time it's not worth trying that ice cream.
Rather unpleasant.
Unpleasant, but also it gives you a little bit of an aversion. So with the gastric bypass, you have probably a little bit more of a help going to better foods because you know some of those other foods are going to make you feel kind of miserable. So next time you won't even try them.
So what you're saying is most of the operations we do today aren't designed to make you vomit or have diarrhea. Now, it's interesting, we also talk about risk-benefit ratio for any intervention, whether it's surgery or medications. And 15 years ago, when these criteria came out, obviously the risk of surgery was much greater. Today, the risk of surgery is much less. And part of that has to be due because we do these with minimally invasive techniques. Why don't you talk about that and our experience?
Well, the minimally invasive techniques are basically surgery with the small incisions. And we do most of these operations, whether it's the band or the bypass, with 5 little incisions. But when we started this, we did all of these with large open incisions. And they have a higher complication rate, more time in surgery. Most people and patients and doctors think, oh, you're going to see it better when it's open. We actually have found that laparoscopically, we see things so much better because it's magnified up on a TV screen. So we feel that every little detail of the surgery, whether it's each stitch that we put in or whether it's each part of the surgery, we feel that it's performed much better laparoscopically because we're seeing it so much better. But also the long-term results we've shown, because we have our data from before open, and what we do mostly now is the laparoscopic or minimally invasive. We have better outcomes as far as in and out of the hospital, operating times, back to work, less pain. You name it, in general, the minimally invasive surgery is just a tremendous improvement in these operations.
So better operations, safer operations, and medical treatment that just doesn't work.
Well, being overweight is dangerous, but how dangerous is the surgery?
Well, you know, as you said before, because we're doing almost all of their operations minimally invasively, they're much safer than they were today. And across the board, there's been a tremendous reduction in the operative mortality, the risk of dying from the operations. I think because of this, because we're doing a better job of educating, because a lot of factors. But you have to look at the operations and the risk of the operations in terms of what's the risk of dying from the disease. And again, if you take 100,000 patients with metabolic syndrome or with morbid obesity and put them against patients who have surgery, clearly in almost every study, the patients who have surgery outperform those who did not have surgery.
So you're saying for patients that have medical problems that go along with being their obesity, like the diabetes and hypertension and hyperlipidemia, they're better off having surgery than not having surgery?
Absolutely, absolutely. The studies clearly show this. We know this in our practice. I mean, most of us who have children, we know that if our own kids have this problem, they'd have surgery in a second. You know, if we can find a good surgeon, of course. But now, what's the risk of surgery compared to other surgeries? And again, there's been such a remarkable progression in the safety that we can say band, bypass, a lot of the modern operations we do today have a safety record equivalent to, say, taking out your gallbladder, or even better than doing an open heart surgery or having your hip replaced.
Well, I think some of the studies even show that the results with the gastric bypass or the band, as far as dying from a surgery, much less than other surgeries if you compare the extent of the surgery, but even less than some of the gallbladder surgery studies out there. And so gallbladder surgery isn't just a quick little easy surgery if you start looking at the same numbers that we look at for weight loss surgeries.